So that then moves on to our medical factors. And back in the 1990s, 1980s, we were really quite conservative. And the selection criteria, you had to be pretty fit. You had to be young, you had to be fit, you had to be slim, and you had to have a surgeon who could do an operation in under an hour. So, not really where we are now. But then it came along, no, we're not having that anymore. We've got to default to day surgery. And the guidance then came out, actually a patient should only be excluded from day surgery if after a thorough preoperative assessment they have been deemed inappropriate. So patients should be scheduled for day surgery and then, if absolutely necessary, move to an inpatient pathway, rather than a surgeon in clinic thinking, oh, well, maybe they're a bit frail, maybe they've got a bit of angina, I'd better err on the safe side and book them as an inpatient. No. If the procedure is appropriate for day surgery, you book them, and if the preoperative assessment staff deem that there's a problem, then they can refer to the anaesthetist and get advice and move if needed. And the bottom line is, you know, we had our criteria back in the 80s, 90s, but I'm sure Scotland's not that much different to Wales, to Devon. Everyone I deal with is fatter, they're older, and we certainly, if we kept the criteria we had before, we'd have very low day case rates. And this is where we've moved to now. So we no longer have a limit for ASA for day surgery, and I'll talk about that in a moment. Neither do we have a limit for age, and there's a huge amount of evidence that the elderly deteriorate when we bring them into a hospital bed. They get disorientated, their routines go out of the window, and they are much better in their own home. We have no limit for BMI, and I'll talk about that. And again, certain medical conditions used to be an exclusion for day surgery, and diabetes was one of them, and there's a lot of national guidance now saying diabetic patients should be managed as day cases, and they do better if they do. So starting with ASA, the guidance now is that most stable medical conditions can be managed as a day case. If they are unstable, they shouldn't be having their surgery at all. So you don't do them as an inpatient, you cancel their surgery until you've stabilised them, optimised them. The only group of patients I would say that that's different for are the urgent cancer patients. And there may be some patients that we need to push through because they're urgent, it's cancer surgery, and they've got particularly unstable diabetes, unstable angina, and the risk benefit is therefore to bring them into a hospital bed. Again, it's not very many. Diabetics. As I said, there's national guidance that we should be managing these patients as day cases. They are better at managing their diabetes than we are. We bring them into hospital, we give them the wrong food at the wrong time, we take their medication away from them, and we completely mess up their control. So as long as you get support of your diabetic nursing colleagues, then really these patients are better managed as day cases. The elderly, I've already talked about that. And we did some work down in Torbay, and we looked at our patients who were over 70 and those who were younger than 65, and we showed again no difference in unplanned admission rate between the older and the younger patients. As I mentioned earlier, we phone all our patients the following day, and again all the patients were or the majority of patients were very satisfied afterwards, and there was no difference if they were younger or older with their perception of their day case pathway. Obesity is the big one. People will get very excited about fat people, and they'll say, oh no, they're a nightmare to anaesthetise, they're a nightmare to operate on, they have lots of complications. They're right, they are a nightmare to anaesthetise, they are a nightmare to operate on. Everything is more difficult, but the difficult bit happens perioperatively. It happens in the anaesthetic room, in the operating theatre, in primary recovery. So what we say now is that actually even the morbidly obese can be appropriately managed as day surgery, but you need the proper resources. You need the expert anaesthetist, the expert kit, the expert surgeon, the long instruments, the big tables. You need to leave longer to do it. But once they're through that, they can still go through a day surgery pathway. And actually they benefit from the short-acting anaesthetics that we use through day surgery, from early mobilisation, and from the day surgery pathway. Now the caveat to that is they may not be appropriate to do as a general anaesthetic on a peripheral site in an isolated day surgery unit because there isn't the backup. But that doesn't mean you can't bring them into your main teaching hospital and still do them as a day case, but through your specialist theatres. And again, we've got some work here to show that in Torbay we've looked at our larger patients, and there's no difference in unplanned admission rates for the slimmer versus the larger patients. Not only that, but they don't contact people for help afterwards. So this is looking at what percentage of patients have had to phone for help the night after surgery, and there isn't a difference between the slimmer and the larger. So medical exclusions are very few. We now say unstable ASA 3 or 4. You'd be sporting to get an ASA 5, which are the ones who are expected to die within the next 24 hours. Any poorly controlled abnormality. Neonates, so that's children below the age of 1 month. So again, that's not excluding huge numbers. Ex-premature infants, so less than 60 weeks post-conceptual age, that's less than 20 weeks from when they would have been due, and that's just the prems, and that's because of the risk of sudden infant death syndrome and apneas in this particular group of patients. And the other group that we exclude are the siblings of children who've had sudden infant death, and that's really partly as support for the parents, and I think just reassurance for us. We would want them on an apnea mat for the first night after an anaesthetic. Again, it's tiny numbers. So what we say now is abandon universal selection criteria. We want an inclusion rather than an exclusion philosophy, and then we'll move on to the procedure rather than the patients.